can see we are quite a number. I can see we are 269 people, 270 people in the group on the call. So welcome to today's webinar. We'll be talking about reproductive genomics. And some of the things we'll be looking at are DSD, genetic infertility, offspring evaluation, familial cancer syndromes, and teratogenicity. Our speaker for today is Dr. Siokawe Lovi. She's a physician and geneticist. She has an undergraduate degree and an MD in internal medicine from the University of Nairobi, and she has a certificate in genetics and a postgraduate diploma in genetics from the University of South Wales. She is currently undertaking her master's degree in genomics from the same university, the University of South Wales. She's a lecturer at the University of Nairobi and runs a genetics private practice in the city of Nairobi. So welcome to today's webinar and welcome Dr. Siokawe Lovi. Take it away.
Thank you very much, Dr. Ondieki, for that kind introduction. So over the next 1 hour, I will be discussing the role of genetics as it pertains to the specialty of obstetrics and gynecology. Okay. So what exactly does a medical geneticist do and what is their role in reproductive genetics? So genetics is a cross-generational diagnostic service. And we know genes are passed from parents through to offspring through reproduction. So that the entry points can be at any point. So that in one case, it might be a child who's affected with a genetic disorder. You test mom and find mom has the same genetic mutation. Then the next entry point might be mom when they are carrying a fetus and they want to find out what are their risks of having a second affected child. Then it can also be parents, where parents are known to have a genetic abnormality, like this gentleman is known to have Klinefelter's, and an advanced maternal agent. There is so carrying out risk prediction and genetic testing either in the embryo or prenatal or even immediately the neonatal period, and trying to determine which genetic disorders the offspring might be affected. So we'll have a few objectives, and I want this to take a clinical aspect. So when we are looking at offspring evaluation, we use 3 clinical case scenarios where you have a non-consanguineous couple who come to you in your preconception clinic. Dad has a genetic disorder, in this case, cutaneous albinism. Mom looks phenotypically normal because her skin is okay. And the question they ask you, will our child have albinism? By the time we are done with this, we should be able to give them up, not very low, high, actually numbers, so that you can predict if they have a high risk and how to test and try and mitigate the risk in the offspring. Another entry point for offspring might be a couple whose previous child was affected by the genetic disorder, be it Down syndrome or autism, and they want to know whether their child will be affected with the same genetic disorder and what are their actual risks. A third one would be a lady coming in who had an uneventful pregnancy and delivery, but baby died in NICU. So she's coming in, no living child, and is considering having another baby, and they want to know, okay, what went wrong the last time so that I know how to mitigate the risk. Then we'll go a bit into genetic test interpretation for the common disorders that manifest in obstetrics and gynecology, like genetic infertility and disorders of sexual development. Then we'll touch a bit about how to cascade testing in a family which seems to have a familial cancer syndrome and how that is carried out. So when we talk about genetics, what are we talking about? At the end of the day, what determines who you are phenotypically is your nucleic acid sequence. You have a genetic code, which is just your C, T, G, and A. Is what determines, the sequence is what determines why one person is very tall, another one is very short, another one is light colored, and the like. And where is this nucleic acid sequence? It's domiciled in your DNA. Your DNA is found in the nucleus in forms of chromosomes and in the mitochondria in form which is exclusively maternally inherited. And it's your DNA sequence that determines your protein and function and organism. So that when you talk about your DNA sequence is what you're talking about, the genotypic sequence, and phenotype is what you're able to see with your eyes. So there's an interplay between your environment and genes, right? So that it's not exclusively that your genes determine how, your genotype determines how your phenotype will be. And the best way to evaluate how environment interacts with genes is looking at twin studies. And it's been shown in a case where maternal fetal alcohol spectrum disorder, where the twins are monozygotic, meaning they have the same genetic sequence and they have the same environment, which in this case is fetal alcohol exposure. The concordance rate is almost up 100%. But then when you have dizygotic twins, which they are they're not genetically identical, but the environment is the same because both of those fetuses are getting the same dosage of alcohol. But the concordance rate is about 60 to 70%. So that it shows even in genetic, there's a genetic predisposition to getting teratogenicity. So that may explain why sometimes you have a child who's been exposed to a very severe teratogen and they seem to have come off not the worst, for where you can have someone who's just had another fetus with a minimal exposure, they come out with profound teratogenic effects. Then when you look at a disorder like autism spectrum disorder, which is increasing, the prevalence currently is around 1 in 100 live births. So that's about 1%. The genetic contribution is about 80% of the children who have autism have inherited the mutation from one of their parents, even if the parents look normal. And then another 10% are de novo mutations, meaning the mutation, the fetus developed a new mutation that did not originate from either mom or dad. And another 10% is environment. And environment doesn't work in a vacuum. Environmental exposure is usually in the background of genetic predisposition. So that even when you look at monozygotic twins, one develops autism. So the concordance rate between monozygotic twins and autism is about 90%. It's pretty high, but it's not 100. Why is it not 100%? They're finding the 10% of monozygotics who are not concordant. They're finding an abnormality. Either the umbilical cord was abnormal or it was the initial baby in a twin pregnancy. So they had a protracted labor so that they can have the genetic predisposition. But there's an environmental trigger that tips them over to getting the phenotype. So how common are genetic disorders? I'm able to see the chat box. I want us to just take a quick poll. How many of you have delivered a baby with cutaneous albinism? This is a CME largely for obstetricians. Maybe you can have in your X number of years, how many of you have delivered a baby who had cutaneous albinism? Because it's pretty rare. It occurs in about 1 in 18,000 live births. Spinal and muscular atrophy. So we are not able to. Okay. Spinal muscular atrophy is also pretty rare. This one will be common. Down syndrome. I'm sure most hands will go up, right? Because Down syndrome occurs at a rate of 1 in about 500 to 600 live births, right? So that majority of you will have come across Down syndrome, spinal muscular atrophy a bit rarer, cutaneous albinism even rarer. Now, spinal muscular atrophy and cutaneous albinism are autosomal recessive traits, meaning for the baby to develop the phenotype, they need to inherit the mutation from mom and dad. So that the phenotype might look rare, that it's occurring in 1 in 18,000 live births, but the carrier rate is 1 in 70, meaning about every 70th person you meet is a carrier for cutaneous albinism, and every 50th person you meet is a carrier for spinal muscular atrophy. So the carrier rates are very, very common in the society. Now, what makes the phenotype is the likelihood of that carrier will meet with another carrier and then pass it on to the offspring that makes the phenotype a bit less to occur. Sickle cell, how many of you have handled a baby that's a mom in sickle cell in pregnancy? Virtually all of you, right? So they are not uncommon, and there are about 10,000 genetic disorders known to man. And all of us carry about 10 to 15 genetic mutations of clinical concern. Now, whether they cause disorder in us is undetermined. We might live to be 100, never develop the phenotype, but we can pass on that gene and it develops, manifests as a phenotype in children and grandchildren, even childhood, right? So that how you move from genotype to phenotype is not completely understood, because within the same family, you can have a gene that is being passed on. Dad is 90, mom is in her 50s, right? Granddaughter is in her 20s. Then granddaughter dies at 20 years from the genetic disorder, and mom and granddad have never had any symptoms. So how they behave, it can be the same gene within the same family, but it manifests differently. I've already alluded to the carrier state. And then genetic testing is not absolute. You can have somebody, you know, this is a genetic disorder. About 15 to 40%, despite doing all the tests, and they're pretty expensive. If you do, they can go anywhere between over 100, 150,000 shillings, and you'll still not be able to give them a genetic diagnosis. Now that becomes a dilemma, particularly in reproduction, because if you're not able to map out the genetic mutation, you can't predict the likelihood of it happening in another pregnancy. You can't test for it in the subsequent pregnancy. So I really like this paper. It was a paper that looked at French sperm donors. For somebody to get onto a sperm donor service, the criteria is pretty stringent. So they karyotyped all 10,000 of them, and they found 38% of them had an abnormal karyotype. Now, this is what we call a balanced translocation, because somebody has an abnormal karyotype, but they have a normal phenotype. Now, the catch is this balanced translocation can become unbalanced in the next generation. And this karyotype is done when you're looking at chromosomal material under a light microscope. So it's a gross examination of genetic material. So if this is the degree of the abnormalities in a karyotype, when you do genetic sequence, it's much, much higher. So people are walking around, they are normal, in fact, being considered supernormal because they are being accepted into sperm donor to be sperm donors, yet they have abnormal karyotype. Usually when we come to genetic disorders, there are some genetic disorders that cluster in races, and this is called a founder effect. So that a disorder like sickle cell seems to have developed about 7,000 years ago, somewhere in what was then called the Green Sahara. So that it's a disorder primarily of people of African descent. Then you have thalassemia, phenylketonuria that seems to predominate in people of Arab and Asian descent, and cystic fibrosis in European descent. But it's not a hard and fast rule. So that if you look at the carrier status of cystic fibrosis in the West, it's 1 in 25 in Caucasian. It's only 1 in 65 in African Americans, which means it's only 3 times as common in whites compared to blacks. So that in the US, they actually do screen African Americans for cystic fibrosis. This other paper was looking at cystic fibrosis in South Africans. To get cystic fibrosis, you need to have inherited the abnormal gene from mom, from dad. In that registry, 10% are people who consider themselves fully black. But what this tells us is that they have white blood from mom's side of the family and dad's side. So that you can't completely say, okay, I am dealing with somebody of Asian descent. Sickle cell is unlikely to be the case, even if they don't look to be of another race, right? So when you come to reproductive genomics, genetics, the main thing about genetics is that genes are inheritable. People are very concerned about passing abnormal genes to their families, to their offspring. It's one thing to tell somebody, I think you have breast cancer, or I think you have prostate cancer, come for a biopsy. Most people will tend to do. But then you start telling them, we think it might be running in your family. Perhaps we need to test and bring your children to see if they inherited this mutation. And that one becomes a dicey. So one of the things people want to know, if they have a genetic disorder, will they be able to have a baby? If that baby is born, will they pass on the disorder to their offspring? There's a lot of guilt and blame, which is misplaced because nobody has a say which genes they inherited or which genes they pass on, but it's a recurrent theme. And they also want to know, so what can I do to either completely avert or reduce a risk in the subsequent pregnancies? Then people want to know if the disease is curable or treatable. And by and large, the answer to that is no, right? So when you're talking about genetics, you'll keep hearing about consanguinity. So what is consanguinity and why is it important? So consanguinity is where you have, when you have marriage between people who share blood. And this is defined as people who are second degree cousins and closer. Now you and your auntie's children are first degree cousins to each other. If you have a child and your cousin's child, they are second degree cousins to each other. So second degree cousins and closer, meaning people who share great grandparents. And that cutoff has been found to be the one that gives people an increased risk of autosomal recessive trait. Now, this is a pedigree. Let me illustrate the case here. So here you have grandma. She has one gene of a recessive trait. So she's phenotypically normal, right? So she passes on the abnormal gene to her daughter and her son. They're also phenotypically normal, who then passed it on to their children. Now, these children get married. So when you see a double line, that shows you that's a consanguineous union, because one line is a marriage line, the other one is a bloodline. So now there are two recessive traits running in this family. They are just inherited from that, from the same grandmother. So now this autosomal recessive trait being in both parents puts their offspring at an increased risk of inheriting two mutations that has happened in this boy, and then they develop phenotype. So consanguinity is of most significance when you're talking about autosomal recessive traits, because now you started producing two abnormal genes, both from mom's side of the family and from dad's side of the family. It's not so much of a problem when you're talking about dominant disorders, because if you get two abnormal genes or one abnormal gene, you still develop the phenotype. So a case in point, in Kenyatta, sometime last year, we had a baby who had a very, very, very rare phenotype of an autosomal recessive disorder, and with a carrier rate of about 1 in 4,500. So what is the likelihood that somebody who has a 1 in 4,500 risk went and married somebody with a 1 in 4,500 risk? It's very unusual. And actually, when we went back, we found out that they were first degree cousins to each other. This is in contrast to sickle cell, which has a carrier rate of about, in some areas, 1 in 30 or 1 in 50. So that the probabilities of that happening in a non-consanguineous union is high. So that consanguinity is most important when you're talking about rare disorders. The rarer the disorder, the rarer, the more you need to look for it. And consanguinity is practiced by 1 billionth of the world population. It has a lot of social and cultural benefits. There's a study that is called Pregnant in Bradford, something in Bradford, and they went and looked at the people who are in consanguineous unions. Those mothers were less likely to smoke during pregnancy, were less likely to be behind in their utility bills, right? So then it's 1 out of 8 people in the world practice consanguinity. So it's something we need to get into the habit of looking for, particularly practicing genomic medicine. Another thing you can't escape when you're talking about genomics is a pedigree, right? And I would like to compare a pedigree to a patograph. It's a graphical representation of the family tree. It gives you a lot of information, and it's the cornerstone of genomic medicine, and it cannot be bypassed. So that anytime you meet a geneticist, you'll just find them drawing pedigrees and trying to interpret, right? And we take a pedigree, we say minimum 3 generations. The person concerned and their siblings and first degree cousins are 1 generation. The generation above them, which means parents and aunties and uncles, and the generation lower, children of their siblings and cousins, right? And it gives us a wealth of information. It cannot be bypassed. It helps us understand what the phenotype is, mode of inheritance, quite a bit. It even helps us predict who to do genetic counseling and who to bring in for genetic testing, so that if I draw my pedigree and I see somebody has been adopted into the family, meaning they are not of that blood, I can say, okay, this one, because you have no blood relation, it's okay, this one don't bring, so that it cannot be bypassed, right? And now we are moving, because genetic tests are becoming cheaper and more available. Genomic medicine is being mainstreamed into specialties, obstetrics and everything, so that obstetricians are asking for genetic tests and interpreting themselves, and they are only asking for a geneticist to review when either the tests are coming as a second tier, not initial, right? And of course, the drawback to a pedigree is that you can have information that is not readily available. So that if you're asking a couple from your side, do you know if any of your siblings have lost pregnancies? They might say no, because that information might not be freely available. So that it's very useful, especially when the information is present, but absence of doesn't mean it's not there, right? So I want us to go a bit into the different genetic disorders that are relevant in OBS and GYN and see how to evaluate them. This is something you know very well, right? So that if I'm being given a female who has a disorder of sexual development, I know whether I'm looking at the ovaries, what I need to look at and the like. External genitalia, I start thinking of congenital adrenal hyperplasia, which is one of the commonest. So let me use a disorder like Turner syndrome, right? So phenotype of Turner's is classical. You know Turner's, you know it can't be anything else. So what is the test we ask for? We ask for a karyotype. What are the expected findings for Turner syndrome, right? Top on that list is 45X, or where you have one X and one is missing, right? But that is not the full story. You'll get this karyotype in about 90 to 95%. What happens to the other 10%? You might do a karyotype and find it's 46XX. Remember we said, you know it's your Turner's, right? So what has happened? Two things could have happened. You can have had two X's, but this one's the genes have been silent, so that it's looking and under a karyotype, it has two X's, but functionally one X is silent. You can have both the one X missing or two X's, the mosaism, which means you have both presence of normal and abnormal genetic material, and you just happened to sample the normal 46XX. It can also be a 46XY. What has happened to the Y, right? It has also been silenced. So that ideally this child should have developed into a boy, but because this was silent, they phenotypically behave like a Turner syndrome, right? And there are tests that you can do to try and find out what exactly went wrong with silencing of the particular chromosome, right? So when you look at something like genetic infertility, female is pretty straightforward. If someone is having their periods and everything, that one might not need genetic evaluation unless there is a symptom that is helping you suspect that, right? So that if you're having somebody with disorders, it depends at what level. Are you thinking like your Turner's? Are you thinking Mullerian disorders? And then we have genetic tests you can do to evaluate that. Is it is it a genital disorder, but then it's involving other systems like the heart and the like, so that depending on what it is, there are certain tests, there are certain syndromes that can be triggered and can be looked for. This is something I want to spend time on: premature ovarian failure, right? And it also emphasizes the need of taking a pedigree and not just of the symptoms that somebody presents it, so that if let's say you're taking a pedigree of a family of a child affected with autism, we don't only ask, okay, so who else has intellectual disability of autism? We go sibling, okay, sibling one, they have been fine all their life, so that you take every single medical history, because sometimes different members of the family might manifest with different phenotypes. And one of these classically is Fragile X syndrome, which affects different people differently. So that if you have a male, it's an X-linked dominant disorder. If you have a male with a full mutation, they develop severe intellectual disability, your autism spectrum disorder. If you have females with a full mutation because they have two X's, they can either be asymptomatic or mild intellectual disability. Now, females who have the pre-mutation present with premature ovarian failure, so that you can be having a family of girls where people are going into their menopause into 30s and 40s, right? So that this might not have come out had we not taken a pedigree, right? So then now we go to male, right? So unlike females where genetic evaluation is triggered if you pick an abnormality in the female, in male it can also be carried out in a male who looks phenotypically normal. And phenotypically normal here we mean normal physical appearance and normal sperm appearance, right? And if you're looking at genetic infertility, the thing we want to look out most is Klinefelter's 46XXY, where they have an extra X chromosome. And why is this? Klinefelter's occurs at a rate of 1 in 1,000 live births. That is 0.01. When you look at oligospermic males, the rate of Klinefelter's is at 5%. When you look at azoospermic male, it's at 20%. So it's the single largest predictor of male infertility, right? And then it also, the males, we start triggering, evaluating for genetic infertility when if they have normal sperm count and everything is recurrent pregnancy losses and repeated failures of assisted reproductive technology. So you have a gentleman who you know how you have Klinefelter, you do your ICSI, they get a baby. Remember the outcomes can either they get a phenotypically normal, genotypically normal female, genotypically normal male, or they can have extra chromosomal material. So that if you have somebody with an abnormality, either mom or dad has, it's always prudent to, once they have an offspring, to evaluate for it earlier, right? And then when now you're looking at things like obstructive azoospermia, if you're doing one test, cystic fibrosis, why is it? Remember, first they said looking black doesn't mean you can't have cystic fibrosis. 80% of bilateral congenital absence of the vas deferens, 80% of the time it's caused by cystic fibrosis. And people who have cystic fibrosis, 80 to 85% of them have either bilateral or unilateral absence of the vas deferens. So it depends on what you are looking for, right? So that if you're looking at a male, we've talked about that, so that if you're looking at the reproductive system, whether you're looking at disorders or sexual development or infertility, the first test we also always do is a karyotype. If your karyotype is normal and you still think, no, I think that girl still has a Turner syndrome, you can do other molecular tests to try and find out, are the genes on that X chromosome I'm seeing or Y chromosome I'm seeing been switched off, right? And then, of course, if you have an abnormal karyotype, now you're able to define what that karyotype is. So that if you're talking about reproductive system, the initial test is always your karyotype. And then there's quite a bit of genetics still in clinical trials where people are trying to find out, okay, are there ways you can predict why people have recurrent pregnancy losses so that you can try and correct for them, right? So this was a very interesting paper that I came across. They were looking at a certain marker that predicts DNA condensation, right? And they grouped the males into three. They grouped fertile men, they grouped men with normal sperm count, but with recurrent pregnancy losses, and the third group was infertile men. So this marker was highest in men who are fertile. And the men with normal sperm count, but recurrent pregnancy losses, their levels approach those of infertile men. So you can have somebody, everything, your morphological examination of their sperms, everything looks normal, but then there are some molecular markers that are predisposing them to infertility, right? And then female factors, recurrent germline aneuploidies. Let me use non-disjunction Down syndrome. The likelihood of a 25-year-old having Down a 25-year-old female having a baby with Down syndrome is 1 in 1250, right? When that at age 25, when she approaches age 40, it approaches 1 in 100. When she gets to 45, if she's able to have children, it's 1 in 30. So the biggest predictor of aneuploidies when you're talking about Down syndrome is female, advanced maternal age, but that only accounts for about 80 to 90%. So what happens with your 25-year-old who's had a baby with Down syndrome and now is coming for a second pregnancy counseling, and they're wondering what is their risk? So their risk has been downgraded from the 1 in 1250 to 1 in 100, even say, because it looks like she might have a pool of germ cells that have the aneuploidies. And the other things people are trying and find out, are there ways to prevent recurrent pregnancy losses? So genetic complications of IVF. There's a group of genetic disorders which are called imprinting disorders. There's a normal physiological mechanism called imprinting that happens in the post-zygotic stage. That is by about 7 to day 10, right? And it requires communication between the zygote and the placenta. When you've done IVF, at that point, what do you call it? Yeah, at that point, it's in a petri dish. So it's lacking a placenta, so that there's an increased risk of imprinting disorders. The good thing, it's very, very rare. So it occurs in about 1 in 100,000 successful IVS. It can't be tested when you're doing your PGT because the process is not complete. So if someone is really keen, and it's so rare that it's not even recommended to be done, so that if somebody is having a baby who's conceived by IVF and they go on to develop some congenital abnormalities, that would be a good candidate to evaluate genetically and find out, is it that it was because of advanced maternal and paternal age? Was it a consequence of the IVF process? Was it they inherited an unknown mutation from either mom or dad or the like, right? So then now we come to the cases we were discussing earlier, and that will be, that has been quite a bit of what I'm handling. So we said you have a couple walking into you. You can tell dad has albinism. Mom is phenotypically normal. So the first thing when you have a genetic disorder is you want to find out what is the genetic disorder. So you have to characterize it. And then what is the mode of inheritance? So that we know cutaneous albinism is an autosomal recessive disorder. So even if mom looks phenotypically normal, she could still be a carrier of one abnormal albinism gene. And now if it meets with the one for dad, there's a very high risk of pregnancy, right? So how do you approach this? We calculate the risk, which I've said. Then you draw a pedigree, establish consanguinity, because if dad has albinism and is related to mom, her rate is much higher than if they were unrelated, right? And then if we genotype mom and we find her genotype is normal, all her children will be carriers, but the good thing is that they will be phenotypically normal. Now, if mom by chance happens to be a carrier, and that is in a rate of 1 in 70, there's a 3 in 4 chance that their children will have albinism. So if she's a carrier, there's a very, very high risk that their offspring will actually get albinism. So the goal really is, if you have one parent has an autosomal recessive disorder, you want to look for the same mutation in mom, right? And then now evaluate, because if mom doesn't have, then the children will not get the phenotype. They may just inherit one abnormal mutation. But if by an off chance, mom has one of the abnormal genes, then you're in big trouble, right? So that if you're looking at something like when you are being called to review your high risk pregnancies, where you have sickle cell in pregnancies, ideally should be following what we do for your HIV, right? Test the partner from the same mutation, test all the other children at home, test baby. And you know, a lot of our mothers fall off from the postnatal clinic very early on. So we probably want to test them either post-delivery or first postnatal clinic. And of course, we test children regardless of paternal status, right? And then we enroll the baby. So that if you find baby now is sickle cell at birth, now we enroll them in clinic, so that we stop having people dropping off earlier, right? This you already alluded to. Whatever autosomal recessive disorder one parent has, characterize it, look for the mutation in mom, right? And then now the challenge comes in once you start delving into people's genetic material and you start doing trio testing, which is testing mom, dad, and fetus, you have the risk of finding out one parent, either one or both parents is not the parent, right? Do you tell them, right? Are you covered by law? Because it's either you tell them, okay, look, mom has sickle cell, dad is normal, but the baby has sickle cell. So that is either likely that that is not the father. If you tell them, you can be taken to court. Should you not tell them and they go and read, they still are likely of being taken to court because there are no laws that guide us here in Kenya, right? And then now the more troubling one is when you discover that this child you're evaluating is a product of incest, particularly when you're talking about maybe the person, one of those people was a minor, right? Because now you're talking about criminal, a criminal event, right? So that how to navigate that, then we need to start even, and you don't even need to do genetic testing. Sometimes when you draw that pedigree and you see the way things are flowing, you can tell these lines don't, these relationships are not what they are presented, right? So then now we go to the other scenario we discussed, where you have a previous sibling affected and they're trying to find out, okay, we had a child who had autism spectrum disorder. We want to know what is the likelihood of getting another child. So overall, okay, autism has very many genes that cause it, but by and large, the recurrence risk is about 30 to 40%. It's pretty high, right? Anytime you have a genetic disorder, the algorithm is the same. First, define the phenotype, define the genotype in the person affected. So we look for the mutation in baby, then we try and find out, is it a de novo mutation, meaning it's new, or did they inherit it, right? So that you can calculate for the next pregnancy. This comes with a tremendous amount of guilt, because once you start testing mom and dad, what at the end of the day you're communicating is that this abnormal gene came from one of you. There's a lot of guilt that comes with that, and there's a lot of blame. You know, this didn't come from my side of the family, right? Right, so that if you get, let's say the entry point was a baby who had, the previous pregnancy was a congenital adrenal hyperplasia, you mapped out in mom, their mom and dad are both carriers. So now the risk is that one of an autosomal recessive trait, which is a 1 in 4. We talked about the 25-year-old. So you have somebody with a bad obstetric history and where does genetic come in, right? So this is a mom who delivered. For this case, let's say everything was fine, pregnancy, delivery, right? And even morphologically, the neonatologist at delivery said, baby looks fine, but then the baby died, right? So they are coming to you, they are giving you that history. They have come to you to your clinic. This happened last year, but I want to have another child, and I don't want to go through that experience again. Now it becomes very difficult to know what went wrong, whether the neonate had normal morphology or was dysmorphic. You can't start guessing at this point. So that the move should be towards getting samples when they are still in NICU, it might actually feel a bit insensitive to ask at that point, you know, we need to take these samples, because at that time somebody has gotten a very big shock of their life, but it might help them in the long run, because then they're coming to you 1 year later and you have no leg to stand on, you don't know where to. And it also helps in medical reconstruction, which I'll come and talk about the role of genetics in poor obstetric outcomes, both for mom and baby, right? So that we need to start, even if it's not taking and genotyping, taking at the point in NICU and storing them, right? When people have composed themselves after a month or two, you start saying, okay, this one, you might not be willing to discuss this now, but we need to do this test when the samples can still be run. Then we see, so that somebody's coming 2 years later, then you're saying, okay, this one was found to have had this. Then they are able to get. Because when you're doing genetic testing, you always test the person with the phenotype, right? That we have. And this one will become common. Genetic tests, as the tests are coming down, they'll become quite commonplace, being ordered by both the healthcare practitioners and even patients asking for them upfront. So I want us to discuss a bit about the genetic test and how to interpret them. Always test the person with the phenotype. It's almost impossible to determine the genetic mutation of a family member without the phenotype. And sometimes it might not even be blood relatives. So let's say a mom and dad are saying, we've lost 3 babies and they all died between year 1 and year 2, right? So yes, you can say, okay, that sounded muscular, so perhaps it's spinal muscular atrophy or Duchenne's. Let me look for it in both mom and dad. You are not certain, even those are their biological children, right? Dad might not have been the biological children. So that when you start testing people without the phenotype, there are so many moving parts that you cannot correct for, right? And then you can't collect DNA from tissue that has been fixed with formalin, paraffin. So you either need whole blood or fresh frozen tissue, right? And if you have multiple family members, you want to pick one family member, do genetic test until you get a genetic diagnosis. And then that one genetic diagnosis is the one so let's say in the one family member, you've done serially 10 genetic tests, and the 10th genetic test is the one that showed you the genetic mutation. So in the other family members, you just do genetic test number 10. That is what now we call cascading of testing, right? So that if you get, let's say a young girl is coming to you, she's telling you grandmom died and mom died, right? And I want to get tested. It becomes very difficult to identify the mutations. And for that, you will tell the granddaughter, you have an aunt who seem to have had the same condition. Okay, she's on chemotherapy for ovarian cancer. Please ask her if she's willing to get the genetic testing done so that you know what genetic mutation is running in your family. Now, there is the catch. Granddaughter wants to know, auntie doesn't want to know. The one with the phenotype is saying, you know what, me, that one I don't want to know. So that you can hit a dead end, because now you're dealing with multiple family members and you're trying to get somebody to consent. These are the genetic tests largely that are available, and it depends on what level, right? So that if you're looking at a karyotype, a FISH, and chromosomal microarray, you're talking, now these are your cytogenetic tests. This is the approximate cost, right? And these ones obstetricians are asking for and interpreted. Now, when you're doing the molecular testing, that one can be asked by the obstetrician. If you land into trouble, you can always consult, right? So let's look at genetic testing in either during pregnancy or an embryo. Now, this is the most complex aspect of genomic medicine, the ethics aside, right? Because you have disorders with poor genotypic phenotypic correlation. Let me use this one. So you had a 5-year-old girl who had severe autism and you mapped her genetic mutation, right? And then now you went and tested mom and dad. You found mom with the same mutation, but she's normal, right? So in their next pregnancy, they're asking you, okay, where will this baby fall? Will they be severely affected or normal or something in between? And the answer really there is, I don't know, right? So when they're trying to decide what to do with that prenatal testing, really it can fall anywhere in the spectrum. So it's very good prenatal and pre-implantation, PNT and PGT are very good for disorders where an abnormal genotype means the likelihood of abnormal phenotypes are very high. And aneuploidies are very good for that, because an abnormal karyotype is highly suggestive of abnormal phenotype, but it's not absolute. We saw what happened in the sperm donors. And if someone is carrying to either an autosomal dominant disorder or things like cystic fibrosis or sickle cell disease, right? And then ideally it should be done when parents intend to act on results. Now that NIPT is becoming commonplace, when you read the literature, a lot of cases are happening when mom is coming for clinic, they're being told, okay, go do this test. It's only when the tests come back, they thought they were going to have their blood group and HIV test. They don't understand the weight of the testing being ordered for, so that a lot of pre-testing genetic counseling needs to be carried about. Okay, do you want to do this? If it's abnormal, what are you willing to do with the results? So that if somebody is not willing to act on results prenatally, perhaps they should be omitted altogether, right? And it's not foolproof. When you do, there's no test I can do and say, okay, I'll do whole genome and sequencing, and I can tell which genetic disorders you get, right? So that you can chase, let's say they had congenital adrenal hyperplasia in the previous pregnancy, you're even doing PGT. Then you test for congenital adrenal hyperplasia, you do a karyotype for Downs and the stuff. It doesn't mean that child will get autism. So that you cannot guarantee that that child will not get a genetic disorder, right? That one, you know, right? But I want to spend a bit on point number 4, so that sometimes you don't have to do genetic testing to actually predict a genetic disorder. And I'll give an example. So you have dad who's known to have hemophilia. I know it's an X-linked recessive disorder, right? So I know if I do an ultrasound and that fetus is a boy, it doesn't pass that mutation to his boy, right? And maybe we've tested mom, right? But I know if it's a female fetus, he's obligated to pass the abnormal X chromosome to the fetus if the baby is his, right? So that if you test either prenatally or postnatally and find that fetus doesn't have the mutation, it's either the baby is not his or the baby mutated from the abnormal X to a normal one. Okay, they are both possible, plausible, but one is more likely than the other. So sometimes just doing basic tests can help you predict, right? When you talk about genetic non-invasive testing, that is the way the world is going. When you're doing these tests, 80% of circulating free DNA is from mom, 20% is from fetus. So that when they are removing the circulating free DNA, there's the likelihood that what they are reporting can be mom's undiagnosed disorder, right? And that one can be found out, let's say if you take a buccal swab from mom to find out, perhaps, is this one coming from her or from fetus? And genetic NIPT is not foolproof because you're testing genetic material from the placenta, which might not be identical to the one for the fetus. That's why they advocate you go in invasively and confirm the mutation that you're talking about. Initially, it evolved for your trisomy 13, 18, 21, singleton, but now they're able to do multiple pregnancies and other things. So that like now it's being used to determine which, looking at the rhesus gene, which fetus should I give? Mom is rhesus negative. Which pregnancy warrants giving anti-D and which one doesn't warrant, used for paternity testing. And as the science is evolving, it will be able to do much, much more, right? That I've talked about. When you're looking now at pre-implantation, aneuploidies are good because they have a very high phenotypic to genotypic correlation. So those ones are easy to make decisions on whether to do the transfer or not, right? And now people are exploring, instead of biopsying the embryo, look what is called spent embryo culture, because the embryos excrete cells into the culture media, and they are now trying to correlate whether that is giving you predictable and accurate results, so that people may eventually stop doing biopsies of the embryo. Then the monogenic disorders for pre-implantation genetic testing, it can test about 600 monogenic disorders, but they're not always all tested, right? So the entry point, usually you start, okay, if mom and dad are known to have a genetic disorder, you test for that. Of course, we talked about when you have poor genotypic phenotypic correlation, right? And then when you do PGT, you're doing on a few cells. Is that representative of the whole embryo? When people started doing PGT, it showed how common embryonic mosaicism is and the ability of an embryo to self-correct. And that is why you're able to biopsy an embryo to begin with, right? So when you find embryonic mosaicism, the question is this going to be pathogenic or is it going to correct? Quite a number of them correct, right? But now when you're dealing with your patient in front of you, there is no that guarantee. Now we're talking about your patient in front of you. So it's either you avoid transferring that embryo or transfer. I mean, if it's the only egg that you manage to get and there's no likelihood of another one, perhaps you do the embryo transfer and then now you follow up with invasive testing. But there's a lot of ability of the embryo to self-correct early disorders, right? And then this is the other type of PGT that is done. So when you're doing PGT, either PGT or PNT, you're not sequencing the whole genome, right? But that looks like the future, that people will be able to predict with a pretty decent degree of accuracy, trying to mitigate against genetic disorders, right? And then now we'll talk about genetic testing for products of conception. So you have, it follows the same one we are talking about where a baby died in NICU. The only way you can tell, okay, what went wrong? Is it likely to recur? Is if you test those POCs. And the gold standard is what you call a chromosomal microarray or chromosomal analysis. It's able to detect your aneuploidy so that if you're asking for a chromosomal microarray, you don't also need to ask for a karyotype, right? It costs about 50K plus. So that if costs are an issue, the first test to do is a karyotype. But if you're able to do a chromosomal microarray, you don't need to ask for a karyotype. And this is the results of a chromosomal microarray. We know chromosomes should exist in twos. So you have 2, 2, 2 until you get to number 15, they become 3, right? And then when you get to X, it drops to 1 and a Y1. So that it tells you this is a male fetus and they have an extra chromosome 15, right? And then of course the future people will move so that even when you look at the guidelines for obstetrics, they don't recommend whole exome sequencing. It's still at chromosomal microarray because it's a pretty decent, it gives you pretty good diagnostic yield. But as we move forward, whole genome sequencing for everything will be the future, especially when tests start coming down. So when you're looking at a karyotype is able to tell you two things. First, it's able to tell you the gender, whether it's a normal gender or abnormal, right? Because it always, so that you know this is a karyotype of a female. This one is a Klinefelter's because you have 2 X's and 1 Y, right? And then it's able to tell you abnormal number of chromosomes, abnormal structure, and sometimes it gives you when you have very large gains or losses. So when do you ask for a karyotype? You ask for a karyotype one in anything to do with genetic infertility, disorders of sexual, anything to do with reproductive genetics, the first test is always a karyotype, because what you're targeting is to find out how far the phenotypic sex has deviated from the assigned genotypic sex, right? But outside that, they're starting, and of course, now if you're thinking, if it's a tier 1 test for your products of conception. There are 2 types of Down syndromes and their modes of inheritance are different. Non-disjunction trisomy 21 is where you have an extra 21 chromosome. Translocation 21 is where the extra chromosome on 21 chromosome is actually joined to another chromosomal material. This case is translocated onto chromosome 14. Now this one is the one that is associated with advanced maternal age. Translocation Down syndrome is inherited in an autosomal dominant fashion, so that the likelihood of it recurring is actually 1 in 2 in subsequent pregnancies. So the phenotype is the same, but the chromosomal abnormality is different and the modes of inheritance are different. So when we are talking about genetic test or genotyping, we are talking about the DNA sequence or the mRNA sequence and how it compares to a known reference sample. And there are different types of genetic tests. You can have single gene panel, or going all the way to whole exome and genome sequencing. And then there's a way they are reported, so that if a result comes out benign, likely benign, those ones are okay. Pathogenic and pathogenic are also straightforward. Now, this variant of unknown significance basically means we don't know. So that if you ask for a genetic test and it comes back variants of unknown significance, you have no way of knowing whether that is the one causing the mutation or not. I want to spend a few minutes discussing paternity tests and how to interpret them. So there are two types of paternity tests. There's two-parent paternity test and motherless paternity test. And it's when you're doing paternity test, it falls on a simple premise. This is, let's say this is chromosome 1, right? Baby inherits one chromosome 1 from mom, one chromosome 1 from dad, right? So that if you pick the same points and you sequence, you can predict which one. So that these numbers are not actual numbers, they represent as a DNA sequence, your A, T, C, and G. So here we have put mom's nucleic acid sequence, babies, and dads. And we try and predict, okay. And when you're doing a two-parent paternity test, you're actually doing a paternity test and you're doing a maternity test because you have to match babies' nucleic acid sequence to both mom and dad. So that here at this point where they have tested at this locus, mom's sequences are given the number 26 and 27, baby 26 and 23. So here, that child is obligated to inherit 23 from dad because 26 is shared with mom. But that is not the case because dad is 22 and 24. Okay, that's interesting. The same thing happens here, right? But as we go down, you can see baby is matching with dad. And you're able, it gives you a paternity index and it calculates. So that when you're doing a paternity test, it will give you the two results, 99.99% or 0%, right? And now this is what you call a motherless paternity test, meaning mom, for one reason or another, was not available for testing. So what you're doing is you're just trying to predict. When you see one number here, it just means the nucleic acid sequence here and here are identical. So it means baby here both is identical. So you should inherit that one from that. So they are still able to match even with one parent and give you that, right? So to do a paternity test on monozygotic twins, the alleged fathers are two, right? Because when you do that test, it's not, because it's only looking at very specific points, it's not able to tell you which of these two actual dad, right? So that monozygotic twins are not 100% identical. They are 100% identical until the point of the split. One that got split, they get submission able to distinguish. So that if you sequence their whole genome, you're actually able to tell who's the father of this baby. And even when they are looking at crime scenes, they're able to tell who is the identical twin who left their genetic material at the crime scene. But they're not completely identical. The other genetic tests that can be done, right? I think I'll skip this for now. This we talked about misattributable parentage and how, as it is in Kenya, whether you reveal or you don't reveal, you're likely to get into trouble one way or the other. Gene therapy. So when you're doing somatic gene therapy, it cures the parent, but not baby. If you're doing germline gene therapy, it cures offspring, but not baby. So that mitochondrial replacement therapy, as you're very well aware, is in the market, but you can't do germline gene therapy for nuclear DNA. So you can't say, okay, both mom and dad have a genetic disorder on their nucleic material. I would like to have germline gene therapy. Okay, that is the long and short of it. So this one I talked about. I will just spend about 3 minutes talking about teratogenicity, and I'll use congenital adrenal hyperplasia, which is both a genetic disorder and is teratogenic to the female fetus. So now we are trying to use genetic tests to try and assuming the entry point was a previous pregnancy affected by CAH. So you know this is and you mapped out dad and mom, so you know this is a fetus at risk. We are worried about virilization, particularly virilization in the female fetus, which is complete. Female external genitalia is complete by week 8 and 9. So we start your corticosteroids at conception, right? Or immediately they discover. So we are trying to determine at what point can you, one, confirm that this is a male fetus, so we drop the corticosteroid, or what is the earliest we can confirm that this baby doesn't carry the mutation and therefore doesn't need the corticosteroid. So that if you are using traditional ultrasound with sex determination, it's 13 weeks, but then it's even when you're talking about normal external genitalia, if you're thinking about a typical, it might go further. That's a bit late. Are we able to predict earlier? Then comes your genetic NIPT. At 10 weeks, I can do and out if this is a male fetus. And then that tells me, okay, I'm not worried about virilization. Currently, you're not able using genetic NIPT to test for the mutation in test, but those ones will come as the tests get refined, so that now we are left with either looking for the mutation by doing invasive prenatal testing to determine. So gynecological cancer, this one we had already talked about, where you use the family member with the phenotype. Then now you have pathogen genomics, where you're having molecular testing, replacing your conventional culture medium, right? And they have a better sensitivity and specificity than the conventional current medium, right? And it's what is also being used for the self-test HPV DNA kits. So that if you're having a patient with a suspected STI, and you think, I think it's pathogen A, when you're asking your lab, you need to find out, because they have different panels that test for different tests. So that, let's say if you're looking for chlamydia, you want to make sure the panel you're asking for has chlamydia. But how usually this, so that if you have one, if you're not sure, you want to ask for the panel that covers at least the pathogens you think are most likely, but it should have the pathogens you highly suspect. So that one, please liaise with your lab, and then they'll be able to guide you. So the last part of my talk, I want to discuss the medical legal aspects of genetic medicine. And I want to start with baby, right? So that the incidence of CP is about in 2 per 1,000 live births, right? So that genetic disorders are increasingly being found to be the cause of cerebral palsies. So that about a quarter of cerebral palsies are attributable to genetic disorders. And the interesting thing is, if you have a fetus with a genetic disorder, when it comes to labor, that fetus is likely to progress poorly, right? And now require extra maneuvering for delivery. So that what is being attributed to birth asphyxia and obstructed labor causing cerebral palsy might actually be the genetic disorder, right? So it might be a good thing to start looking into, especially if you're running a maternity unit and you want to do clinical audits, you want to make sure you're not labeling cerebral palsy due to poor progress of labor, so that that child receives appropriate care, and also to mitigate against malpractice suits. In the West, physicians are being sued for not doing genetic tests, particularly surrounding prenatal testing. That will not be an issue here, right? Right? And then now we need to start looking into the case where physicians' genetic testing might help explain some of the poor outcomes. Let me use maternity, right? You have mom, a young female, robust health, didn't have any underlying disorders, goes to theater, doesn't, or poorly reverses from anesthesia, right? Family is up in arms. So now, could that be their genetic profile, their pharmacogenetic profile, that made them to metabolize that drug abnormally, right? So that if everything was done by the book, I mean, the anesthesiologist, she's been doing this for many years, because we all have genes. How we metabolize drugs is different, right? So that if you're having things that are not explainable, perhaps the patient's pharmacogenomic profile might explain that, right? And then, like now, what we said, sorry, it's going the wrong way. Poor outcomes in baby. So that, like we said, the nature of medicine, it's very dramatic during hospital. Things cool down, but a suit is mounted either months or years later. That time people have been cremated, buried, everything. So that perhaps you need to start preemptively doing this with, especially maternity, because you know those ones tend to create a lot of emotions lower down the line. So that people can start looking, okay, this poor maternal or fetal outcome, could it have been due to some unknown underlying genetic disorders? You know, those where a mom died during theater, they go and do not a CS, called what, a post-mortem, inconclusive, right? Everything was done by the book. People are not understanding. Perhaps the patient's pharmacogenomic profile made their drug metabolism behave in a rather unpredictable manner. So that is something to look into. That was the end of my presentation. I would very much like to thank Dr. Diana Ondieki for graciously agreeing to moderate this. The KNH Research Department, led by Dr. Kinuthia, Dr. Ngumbao, Mr. Menda, and Nelson. President, led by Dr. Kirekia on sorry, the audience. Thank you very, very much.
Thank you very much, Dr. Ilovi, for very elaborate and expressing to us a very important topic. We're about 1,111 attendees, so that is not a small number. And we appreciate everybody who was able to make time to attend this meeting. So for those who are wondering why we have a physician on board, it's because once we have someone in genetics, whether it's a pathologist, a physician, or even a biologist, for the fertility specialist, you really have to work closely with them. Because I'm even seeing there is one question here that has been posted. What is the advice you give to someone who has had more than 3 failed IVF cycles? So this is someone who actually needs a pre-genetic testing. So, and that means essentially that we have to work closely with the geneticists. And I'm sure you've seen, we have these women with either inability to conceive. Of course, sometimes you find it's the male factor infertility with cystic fibrosis, or you find various aspects like the Klinefelter with oligospermia. So there are all those various things, recurrent pregnancy losses, and also in pregnancy, the people who have outright congenital anomalies, like we see in Down syndrome or the trisomy 18 and 13. So I just wanted to express that of concern, especially to the fertility specialist, and I can see we have several eminent fertility specialists on the call. We actually, for someone who's having a concern about either transferring this to the offspring or not being able to conceive because of a problem, definitely working with the geneticist will come on board. So it's not something we'll only consider for chromosomal abnormalities. And you had already explained, so just to emphasize, we look at everything, the single gene defects and also the chromosomal disorders. And just to name a few, so single gene would be things like cystic fibrosis, Huntington's disease, the thalassemias, the sickle cells, the Marfan syndromes. So there are those things that just outright are of concern and someone does not want to pass it to the offspring. Chromosomal disorders, those ones we know, the translocations, the deletions, the inversions, the aneuploidies, the trisomy 21, 19, the Klinefelter, the Turner syndrome. So all those are of importance. So both the single gene defects and also the chromosomal disorders. And there was something you said about, so let's say, and this mostly applies to the older woman, because we know the older someone becomes, you get fewer eggs, and those fewer eggs tend to be of poor quality. And the embryos you get out of them tend to have a higher rate of aneuploidy. And yeah, so if those are the only embryos you have, that's what you're going to transfer. Because at the back of our mind, we know there's that possibility of it being able to self-correct. So the verdict does not end with the geneticist. So in concert with the embryologists, all of us can just decide, yes, this is what we have, and we'll still transfer.
Go with it.
Hope that it will, yeah, self-correct. So just to go into some of the questions that have been raised, I'll just read them in the order that they came. So are we experiencing an upsurge of genetic disorders in our context, or it's because we are more aware about them and we have better access to the right diagnostic skills and tools?
Okay, thank you for that. The answer is both, but they are definitely increasing. Let me use something that is increasing globally and people are trying to discover why. Something like autism, so that the phenotype of autism doesn't require genetic testing. So that people can tell you there are way more autistic children now than they were 20, 30 years ago. And when you're looking at the statistic, worldwide, it's about 1 in 100. That's what WHO gives. When I looked at the data looking at South Africa and West Africa, now they're looking at people who are closer to us. They're reporting about 1 in 80, 1 in 120, right? So it's about there. When you look at US data, because they screen all their children, I think at 9 months and 18 months, it's at 1 in 44. So it's going up, right? And when you have, so how genetic material is passed on from one generation to the other tends to remain pretty static. So that if you start seeing an upsurge of genetic disorders, it's something in the environment. So there must be something in the environment that is increasing autism. There's a paper I saw recently that is starting to suspect paracetamol, but when you see an upsurge of genetic disorders, there's something in the environment. A very good example is type 2 diabetes in adults. It's a genetic disorder, right? So that the genes, the number of genes circulating in the population now is not different than they were 100 years ago. But the fact that now you're having people living a sedentary lifestyle of this, which is now the environmental modifier, is what is giving you an upsurge. So the question is trying to understand what is causing the upsurge. Of course, when you're starting to look at genetics, if you have a disease that was not there, let's say sickle cell or cystic fibrosis, and suddenly you're finding, you must find out, okay, has there been an influx of people from another part of the world? But yes, the answer is they're increasing both in number, but then also people are now starting to get a diagnosis, so that the children who are being labeled cerebral palsy are now starting to get definitive diagnosis. This is Fragile X syndrome, this is autism, so that they are starting to get definitive, or this is an inborn error of metabolism that gave them some intellectual disability.
Thank you for that beautiful answer. I've also gotten an aha moment, and I'm sure also Beatrice Murage is also very happy. Because if you know the patterns and you know how things have always been, so if there's a change, it points to something. And being the epidemiologist, my mind just quickly ran to, so there's something. So we need to get to the root cause and be able to address the root cause. So it actually just goes beyond being able to handle just the one patient in front of you, and you can be able to go further and be able to address issues in the environment as well. I'm seeing Dr. John Kinuthia has said he wants to answer this question. Maybe you can allow me to let you answer this at the end. So are you able to tell us the statistics, see that we're able to know the past? Is it possible to know the predominant genetic disorders in Kenya?
There are no data. So what we are quoting are largely European data. African genome is the most poorly characterized, right? So that so the answer to that is no, by and large, because it's not been done.
It's okay, but we have to start somewhere, and I guess
yes, it's in progress. It's work in progress.
Yeah, so thank you for that. Someone else has asked question regarding albinism. So both parents look normal. They have 3 children. The eldest and the youngest are daughters. Both of them have albinism, and the son is normal. So who do you think is the carrier? And can both parents be the carriers?
Okay, thank you. This is a very excellent question, because you have a genetic disorder, and once you have a genetic disorder, you first characterize it. So you defined it, it's albinism. What is the mode of inheritance of albinism? We know it's autosomal recessive. So it means mom has to have the abnormal gene, dad has to have the abnormal gene, right? So that if you're giving me another disorder where it's autosomal dominant, I know it, and even your pedigree will help me, so that I know it's only one parent who needs to have them. So once you characterize the mode of inheritance, you can start predicting who contributed to the mutation. So that albinism means both parents are carriers. If they are normal, they are both carriers. I've answered that. Yes. So in that case, both of them would be carriers, because we know it's an autosomal recessive disorder. So another question.
Oh, so I was asking, Is consent
Yes.
required for genetic test to be done?
Sorry, I didn't hear consent.
Yes. Do we get consent for genetic tests?
The consent I'm getting is even not for the genetics test alone, is so there is that, and then it's for if I go and find that dad, let me not say even both parents, like dad is not dad, what will you do with those tests, right? Consent is a good thing, right? It's not mandatory here because there's a gap, but it can cover you later. So that if I'm having a discussion, so then if I start doing all this thing and I find out people are not who they think they are, right? So that even to cover yourself. So the long answer to it would be good to get consent so that people understand what you're testing for and what the implications of those tests could be.
We've also always known that these tests are pretty expensive. Like they used to be 50,000 and above. Now it has come down to the range of tens of thousands to 20s of thousands. So has it become to a point where it's affordable? So because we frequently come across these cases. So what is the cost for further genetic testing?
So the good thing is that the prices are coming down, and they are coming down quickly because one, the patents are running out. The people have made money off their innovation. So in the next, they're still prohibitive, yes, but they'll continue to come down. They're still prohibitive to a number of people. But then what is the alternative? You know, because not having a diagnosis sometimes is more costly. So they are still prohibitive for the vast majority of patients, but they'll keep coming down. Because even what they were 2 years ago is not what they are now, like you said, Dr. Ondieki. So there is hope.
Yeah, there's hope. I also feel that we also need to inform the public that these are available, because some don't even come to the hospital because I think we only address the people who actually seek us out. But I think there's also a role for community engagement.
Yeah.
So Mary Gadogo is asking, what would explain a couple having 2 children and both of them with severe autism?
So anytime one child has a genetic disorder, likelihood in the next pregnancy is high, right? So that entry point is always the first. Let's say they had one child first, would be to map the mutation in baby, look for it in mom and dad, and then predict. So that overall autism rate is 30 to 50%. That's approaching 1 in 3. It's not small, right? But without actually knowing the exact genotype for baby 1 and baby 2, I can't tell you exactly what went wrong, right? But overall, when you have an affected child, the likelihood of another affected child is high.
Yeah, because I also saw in your data there is an 80% genetic predisposition, environment. So like majority of it is genetic.
Yes,
Dr. Alfred is asking about BRCA gene mutations, Lynch syndrome. Are we able to offer gene testing for high-risk groups in Kenya?
Yes.
If possible, where and how much?
Okay, so now you're talking about your inherited cancer syndromes, right?
Yes.
So then your entry point is somebody with colorectal cancer or breast cancer, right? You take your pedigree. Remember, everything you said begins and ends with the pedigree. You take your pedigree and you can tell this one is running in the family. So we look for the mutation in the person with the cancer. How much will it cost? So if you're doing a single test, it can cost about 20K. If you're doing the extended, it can cost 50K, right? So that in the first, the initial person with cancer, you might do sequential testing and you end up doing, let's say, even 150,000. But you find the mutation after you've done the 6th test, right? So you find, in this family, this is it. So the other relatives, you don't need to subject them to 6 tests. You can just do the 6th test so that it's expensive financially, but it gives people peace of mind because people those who want to know, they can know whether they have the disorder, the gene mutation or not, right? If you're looking at colorectal cancer and somebody doesn't have the genetic mutation, they don't have to undergo the sequential the routine colonoscopies. So we can't quantify peace of mind, right? They're still expensive, but it starts giving people answers and definitive answers that then now can tell them, okay, I have the mutation, I need to undergo regular mammograms, or I don't have the mutation. And if I don't have the mutation, I can cancel out my offspring. All my 10 children don't have to undergo screening, because it means I didn't get it and be passing it down through my lineage. Of course, their father's lineage is a bit different, but you get the principle. So it depends, single gene 20K or so going up, but the initial investment is high.
Thank you for that. Moses Ndiwe is asking, does age affect genetic predisposition? For example, having a 60-year-old husband and a 25-year-old wife getting a baby with Downs. Of course, we know the older the woman, chances of this, but now he's saying now as regards about 60-year-old husband.
Okay, so when you talk about if you talk about advanced paternal age and advanced maternal age, once you remove Down syndrome and aneuploidies, it's actually the advanced paternal age that is associated with genetic abnormalities, and they tend to be your autism, your non-well-defined genetic disorders, right? When we look at something with like translocation Down syndrome, even if both the husband and the wife were 25-year-old, 90% is contributed by mom, meaning 10% can be dad, right? But an older man, the older the man, it doesn't increase the likelihood of Down syndrome compared with women. It just remains at that 10%, right? So that if you're evaluating, let's say somebody with Downs, and remember these unions break down so that someone can say, okay, I had Down syndrome with my previous partner, I have a new partner, so I want to know your race. So first you want to find out, okay, this Down, who was the contributor? Did it come from mom? Did it come from dad? Because if that person has been removed from the equation, then their risk now approaches that of the normal population. I hope I've answered adequately. So advanced paternal age does contribute quite a bit.
Okay, thank you. So someone is asking that, does the presence of oligohydramnios or polyhydramnios warrant genetic testing? So there are very many causes of these two presentations on a patient. Unless you're suspecting a genetic condition, there is no need, and most of them are actually not. Another question is, NIPT available in Kenya, and what is the approximate cost?
It's available. The cost, I am not sure, but it's available. I mean, any test is available if a sample can get on a plane and be shipped out, right? So it's available. The cost is what I would need to check.
Okay, yeah. At least we know we have that. We can ship them out. Dr. Mishra Pallavi, any idea if we have hemoglobinopathies other than sickle cell disease in the Kenyan population?
They are there. There was a paper I was reading where somebody went and looked at thalassemias in adolescents who are living in Nairobi, and they found it. So that what makes people start looking for genetic disorders is when you're having phenotypic. So that a lot of your hemoglobinopathies, other than sickle cell, tend to be, I would say, relatively asymptomatic. So that a thalassemia, somebody might get to adulthood when they're getting their medical done for work, they are found to have abnormal RBC, somebody follows it up. But other than that, there's underreporting, largely because they don't tend to be as dramatic as sickle cell in their presentation.
Another question, Turner syndrome, is it passed genetically?
Okay, Turner is interesting. So how genetic disorders are passed generation to the other, one depends on whether they affect fertility, which Turner's does, and whether they result in death in infancy. So that Turner's, the majority tend to be new because somebody with Turner's has almost little to no chance of reproducing, right? Then also disorders where people die in infancy are unlikely to be passed on. So the answer to Turner's, of course, there's no zero. Somebody with Turner's, there's no absolute zero in medicine, but it's highly, highly unlikely to inherit Turner's simply because fertility there is essentially non-existent from a population level.
Okay, thank you. The questions are coming hot and fast,
Mm.
and I know our time is yeah, we are coming to an end. So maybe even as you give us your contacts, so what is the cost of a paternity test in the private and public settings? And are you willing to share your contacts?
Yes, I can. I think Kemri does at 25.45, right? It depends on where you're based, but let me talk about genetic testing in whole, right? Any big lab, especially a lab that ships out samples, is able to do genetic testing. And different labs have different prices. And then because you're talking about large sums, that difference in 10K is quite a big save for patients. So I'd encourage you, just talk to the labs that you use. They will give you the list, and then now you can inform your patients so that they have a range. But these big labs that are shipping samples are able to do.
Yeah, but I feel this cost has come down significantly.
Yes,
it should be about 8,000 now. So again, Misha is asking, for poor obstetric outcomes, can umbilical cord sample, the umbilical cord, can it be sampled for preservation, or do we need a fetal skin sample?
Umbilical blood is good because the easiest tissue to extract DNA is blood and saliva. But then how is it being preserved? Because it needs to be fresh whole blood or fresh frozen tissue. If you're now talking about poor outcomes, perhaps you need to do both. Because if you find one sample has failed, then you have nothing to stand on. So that they can run sequentially. You submit 2 samples. I've done that. You submit 2 samples. You say, okay, run the blood. If you're able to extract DNA, we don't have to use the tissue sample or something like that.
And for people who might need the stem cells, do we offer preservation of placental tissue? Is it something we offer in the country?
That one I don't know.
So someone else is asking, I have a relative who, she has 8 children, but 6 of them are okay and 2 have albinism. Please explain, but I'm sure they were there from the beginning. They must have seen the diagram that you showed us, but you can tell them again.
Autosomal recessive. So cutaneous albinism means even if mom and dad are okay, they don't look like they have albinism, they are carriers of the gene. So anytime you have a genetic disorder, is understanding what is this genetic disorder, what is the mode of inheritance, and then you're able to predict. So that even the other 6 children who are okay could be carriers. So that when you're testing, you might want to tell them, okay, when they become adults, these are the 6 children, you might want to know your carrier status for albinism, because the next generation, if you make somebody with also a carrier, is that.
That explanation is pretty clear. So is dyslexia a genetic disorder?
Yes, by and large. So let me now talk about the whole intellectual autism spectrum, right? It can come because of a genetic mutation. It can even come because of teratogen. So that you're going to have a lot of those disorders because of maybe mom taking alcohol. Alcohol is the most studied teratogen in humans, right? So the long and short of it is that yes, to a large extent.
Okay. Our final question, maybe I'll combine them. So is there any genetic testing for Peutz Jeghers syndrome, and how much does it cost? And then can gene selection be coupled with IVF to ensure that an offspring does not have selected genes? For example, that a parent does not pass on Huntington's. So for the last one, I'll respond yes. Yes, that we do offer. Yes. And we do work together with the geneticists. That one we have to work with them. Yeah. So on the one for Peutz Jeghers.
So now the cost, it can range, right? So I don't have the cost for everything, but I've given you an approximate test. It just depends on the lab and the gene that you're testing. So I just advise you, if you want to know, just liaise with your lab, then they can give you the approximate test. Okay, how much will this cost?
Thank you for that.
Mhm.
Dr. Ilovia, I want to say thank you very much. Your lecture has been extremely eye-opening. I think it was about time we started discussing this kind of stuff. We need to go deeper into the management of our patients. And if it's okay with you, I will share your phone number with the larger group obstetricians and gynecologists. If you want, you can also post it in the group. For the people who are still on the call, they can pick it from the chat.
Figure out how, okay, okay,
Yeah.
I'll figure it out.
And it has come out quite clearly that we need to collect our own data. We need to have our own statistics. So thank you very much, everybody. Thank you very much for taking time to be with us this evening. So have a blessed evening. Bye, everyone.
Thank you very much.
Thank you, Dr.